I'm glad you could join us today. Welcome to the webinar Look Back, Look Ahead, Behavioral Health Policy After the Elections. My name is Angie Fiedler-Sutton, and I'm with the National Behavioral Health Association Providers, and I use she, her pronouns. The National Behavioral Health Association Providers, otherwise known as NBHAP, is a national trade membership association that provides education and advocacy for behavioral health care providers and related entities. We are the leading and unifying voice of addiction-focused treatment programs. We provide membership benefits such as networking and access to compliance information, educational opportunities such as this webinar and our Certificate in Addiction Treatment Marketing, the CATM, and advocacy efforts to keep those in the industry aware of new laws and regulations that may be coming that will affect them. Working in the behavioral health industry or managing an organization in the industry can be incredibly complex and filled with ever-changing information. NBHAP gives you the resources to stay on top of the rules and regulations for your organization to stay compliant. For more information about NBHAP, you can visit our website at www.nbhap.org. And now, it's my pleasure to introduce our presenter today. Andrew Kessler, JD, is founder and principal of Slingshot Solutions, LLC, a consulting firm that specializes in behavioral health policy. His clients, past and present, include the ICNRC, CCAP, and NBHAP. With 20 years of policy experience and over a decade in behavioral health, Kessler is a fixture in circles that advocate for substance abuse treatment, prevention, and research. He collaborates frequently with congressional offices, the White House Office of National Drug Control Policy, the National Institute on Drug Abuse, NIDA, the Substance Abuse Mental Health Services Administration, SAMHSA, and other federal actors. Andrew has written legislation and report language adopted by both the House and Senate Appropriations Committees and has presented orally before such bodies as the Scientific Management Review Board, the National Conference on Addictive Disorders, and the College on Problems of Drug Dependence. Andrew, thank you for taking the time to present today. With that, I will hand the webinar over to you.
Thank you, Angie, and thank you for all attending today. This webinar is something we get to do. Well, I give 2 webinars a year to keep everyone informed, but this one is once every 4 years when it comes to a presidential transition. This is the 3rd time I've done such a webinar. I think the 2nd time for NBHAP. And we are going to talk today not just about the future, but a little bit about where we stand currently and some progress we've made in terms of policy for SUD treatment. The reason we do this is, one, we don't live in a vacuum. Policy doesn't exist in a vacuum. And you can't go forward until you know where you've been. That's true in life. It's true in business. It's true in policy. So the webinar today, you could say it has 2 parts. One, a little bit of a review of the last 6 months of policy progress, because there has been some and it's worth talking about, and a look forward. But the 2 really do kind of blend together. It's kind of like, a trip on a highway. You may pull over to a rest stop and continue your journey, but it's all one journey. So it's all kind of seamless. If you have any questions, feel free to put them in the chat. I try to answer questions as they come up because they're fresh in your head and they're probably germane to what I am talking about at any given moment. So questions in the chat are fine. There's no guarantee I will get to them, but I will certainly try. I have one eye on the chat box, one eye on the camera, and someone in my position, given that we are in the middle of a transition and my computer is on, I may get like pop-up alerts from different news sources or something as I'm talking to you. So forgive me if my eyes, maybe wander around my computer screen because information is coming into us fast and furious. And apologies in advance if you hear barking outside my office door. My beagle does not like it when I ignore her and may have something to say about it. So just apologies in advance if that happens. So let's get started. As Angie said, Andrew Kessler, welcome to my home office in Fairfax, Virginia, about 11 miles from Washington, D.C., where I represent NBHAP, and other organizations in behavioral health policy. And let's talk about the current environment. The first thing I want to present to everyone is not necessarily policy, but data that's important to policy. And this is a great indicator of why my preparation for webinars always goes up to the last minute. Information, you never know when it's going to come to you. And I would say in the last 3 days alone, I've gotten more information that I could not fit into the webinar because my slides were already done than even I could imagine would be relevant. So I may be talking about a few things that have happened in the last few days that may not necessarily be reflected in the slides. But the good news is that overdose data is showing declines. The CDC, which we rely upon for overdose data, and the CDC, which will play a major part in this webinar as we continue to talk, you're going to see. Overdoses, based on the data we have, are on the decline. You can see there, I don't believe in reading slides to you. The slides are there for your information and for your background. But we are seeing across the board some good news. The reasons for this decline are not as clear and continue to be researched. For now, we're just going to take the good news. You can see this spike in overdoses going back the last several years. A lot of people look to the pandemic as a major part of the spike. And in part, that's true. But the real upward trend you can see went from 2019 to 2020. That's pre-pandemic. So something was going on, whether it be fentanyl, other factors, where overdoses started to climb. And then 2020 to 2022, at the very worst parts of the pandemic, you see the real problems for a variety of reasons. Again, presence of fentanyl, strength of fentanyl, isolation, despair, whatever you may, whatever reasons you, want to put in. Overdoses have been on the rise, and we went from year after year of about somewhere in the 70,000s to over 110,000. I believe at the worst, what CDC does is they present their data in rolling 12-month segments. They don't just say, here's 1 year overdoses. They say in the last 12 months, so the data can keep rolling. And we are starting to see that 12-month rolling data show a decrease, first starting in April. I talked to you before about information coming at me. Just 2 days ago, I saw the most recent data from the CDC that brought overdoses in a 12-month period below 100,000. It's kind of cut off there in the upper right. But you could say when these slides were created, not very long ago, we were at about 101,000 overdoses, fatal overdoses, in a 12-month period. Since then, we've dipped a little even lower, and we've come down to 97,000, which makes someone like me, and probably people like you, very conflicted. We are grateful for this news. We are still not pleased at all at the overall number, which needs to decline even further. But it's progress. Remember, I talked about that car on the highway. Every mile you go is a mile less, that you have to drive. So we're doing something right. Is this a direct result of our policies? I like to think that our policies that we advocate for play a role in this, whether they be the availability of treatment, peer services, recovery services, naloxone availability, buprenorphine availability, whatever they may be. I like to think that we play some role. I saw an article the other day that said tests show the strength of fentanyl is getting weaker. Great. I still have the mindset that the work we do strives for a world where fentanyl is not as relevant because people are getting the services they need and are not turning to substance use. But that's a little idealistic for me, especially someone who's working in Washington in 2024. So start with some good news. Here's a little more data broken down by drug, and you can see the decreases, especially what really stands out there is the decrease in heroin. And that's a little good and a little not so good. A lot of people think that the decrease in heroin exists because people who used to use heroin as their primary drug of choice are now seeking out fentanyl. I remember when fentanyl was part of the discussion because fentanyl was heroin and cocaine were being laced with fentanyl. Now we're at a point where people who have a disorder may actually seek out fentanyl. So that's another problem we have to deal with, but it does account for a lot of the decrease we see in heroin overdoses. So what's really staggering is that far column on the right, the other psychostimulants such as methamphetamine, which was all the rage in policy circles 15 years ago, and we don't talk about it anymore. You can see the numbers bear out that we should be. For 5 years, even though I those of us who work on this issue know better, all anyone wanted to talk about was opioids when it came to Capitol Hill and policy. In reality, polysubstance use and the use of stimulants is still a very significant problem that we want policymakers to deal with. So, but the numbers are coming down. We're pleased. So let's talk about some policies that NBHAP has advocated for. I know those of you who receive emails from NBHAP, whether they be from Angie, who is our host, or from our executive director, Pete Nielsen. Sometimes there are advocacy asks. We'll ask you to maybe contact members of Congress or alert you to developments. One of the big things we like to focus on is the SUD workforce. We know there are shortages across the board when it comes to treatment and when it comes to recovery services, but one of the most glaring gaping holes that we see is there's a shortfall in services because there is a shortfall of qualified providers. The STAR loan repayment program was born about, I want to say 5 or 6 years ago. And it is a program by which if you agree to serve up to 6 years in an underserved community, which has the definition of being a mental health shortage area based on the number of professionals, or an area where overdoses exceed the national average, you can work towards paying off tuition loans through this program. It is currently funded at $40 million, which sounds like a lot. In Washington, that's not that much. And when you think about it, if you can work towards up to $250,000 in loan repayments, that's only 4 people per $1 million. This is only 150, 160 professionals we get to train every year through this program. So it sounds like a lot, but to me, it's really just a starting point. However, the Senate has recommended that we increase this to $65 million, due in large part to our advocacy. That's great news. The House has not agreed to that number, so this is not final yet, but it shows some progress in terms of at least one chamber recognizing the need for building the SUD workforce. In addition, other legislation has been introduced by Representative Salinas of Oregon that would modify the STAR loan repayment program, and instead of having it just be loan repayment, have parts of it go towards a scholarship program. Basically, the money would be up front instead of on the tail end. We support this legislation. It's probably easier bureaucratically for those involved, and it gives participants more flexibility upon graduation. So we'll see where this goes. This legislation, I don't think you need me to tell you that Congress is moving quite slowly these days. It has been for a while now. And passing legislation is, become quite a slog. It's always been a slog. I've been in DC for close to 30 years. It's always been a slog, but it's become quite challenging due to the environment in Washington. So, but this is legislation that we have supported, and we feel it could be a great benefit to expanding workforce. When we talk about workforce on Capitol Hill, the question we often get, and a lot of the focus we often get, often comes to the peer workforce. The peer workforce is growing rapidly. There is no denying their effectiveness. There is no denying their the role they're playing. But there's still a lot of questions about what is the role of a peer and what is the right setting for a peer, so on and so forth. Congress has sought to take a few of these issues on. This Peer Support Act is legislation that would expand access to peer-to-peer support services and would have them be able to be reimbursed through federal programs by placing more peers on treatment teams and service teams. So you can see it has bipartisan support, which is no surprise. It's been introduced in the House and Senate, and there it sits. If it does not pass by December 31st, which it could, I'm not saying it will, I would say the odds are against it simply because the calendar is too short. It would have to be reintroduced next year, which I have no doubt it will be. What this bill would do is direct the Office of Management and Budget to revise standard occupational classifications at the Department of Labor to create a category of peer support specialists. This is important because if you are going to be part of the workforce in federal settings, such as Veterans Administration, federally qualified health centers, CCBHCs, certified community behavioral health centers, so on and so forth, your role needs to be clearly defined, which means defined by the Department of Labor, where there currently is no definition for a peer support specialist. The bill would also codify the Office of Recovery in SAMHSA, which currently exists in the Office of the Director. And it would instruct what I feel is the most important aspect. It would instruct the Department of Health and Human Services and Department with Justice to have states reevaluate what it means to have a criminal conviction. We all know that many people who want to become peers may have a criminal conviction on their record. Maybe nonviolent, maybe long in the past. Doesn't matter. In many states, that prohibits you from working in certain settings, especially in healthcare. What this bill would do is allow for studies for states to reevaluate these policies and make modifications if they so choose, because the federal government can't order the states what to do in this regard. But it would allow them to reevaluate their policies and potentially make new policies that would allow for exceptions, possibly nonviolent crimes or what have you, or after a certain amount of time, to be part of the healthcare workforce despite a past criminal conviction. Another act sponsored by Judy Chu of California. I know many of you are in California. I can see in the chat where you're located. Judy Chu represents an area north of Los Angeles. This act would provide for Medicare coverage of peer support services when delivered by federally qualified health centers or rural health clinics, so on and so forth. Another bill that has bipartisan support, but languishes because of the inability of Congress to just move things along. So I wouldn't say there's a lot of resistance to this bill. There's just not a big appetite to advocate for it, which is true of a lot of legislation that doesn't pass. It's not that people are opposed to it. It's just not enough people are in favor of it. So I want to talk about policy progress we've made. Excuse me while I take a sip of Diet Coke. I know many of you are on the West Coast still having your coffee, but for me it's lunchtime, so my caffeine comes in the form of Diet Coke. And a lot of the services we see for SUD, a lot of entry into the treatment system starts in incarceration. We would prefer it did not. We would prefer people were not arrested, of course, and went straight into treatment, but it's a reality. It's a fact of life. And the number of people in incarcerated settings in need of behavioral health treatment is quite a staggering number. I will give you an example. If you live in a rural county in the United States, odds are good that 78% of your county budget goes to jails. Why so much? Healthcare costs. Once you are arrested, it is incumbent on the justice system, not the healthcare system, to provide your healthcare needs. If you're in need of SUD treatment, that's what's included. Now, how much they can do in terms of professionals, medications, that's up for the state to decide. But what we want to see more of is availability of Medicaid for those in incarceration. And we're going to get to why. If you are arrested, it used to be, and in many cases still is, your Medicaid services are terminated. And they are not reinstated until you are released, and you have to reapply for them. It's not like you're released and Medicaid kicks back in. You've got to start all over again. If you are in need of SUD treatment or recovery services on the day you are released from jail, and you have to go through the whole bureaucracy of qualifying for Medicaid, odds are good you're not going to get the services you need in time. We have been part of an advocacy effort that says Medicaid can kick in pre-release up to 90 days. Now, this is not automatic. A state has to apply for this through something called the 1115 waiver. You can see on the map which states have it approved. In those states that are dark blue, it has already been approved, and in those states that are light blue, it is pending. States must cover through Medicaid case management, medication-assisted treatment, and a 30-day supply of your prescription if you require one upon release. So when you are released, you are covered by Medicaid, and services have already begun. Okay, this reduces recidivism. Data bears it out. Okay. Starting in January, states will be required to use Medicaid and the Children's Health Insurance Program to cover limited services for incarcerated youth under 18. So that means if you are, under 21 or former foster youth, the policy requires screening and diagnosis and service referrals 30 days before release, covered by Medicaid. Huge win. Excuse me. Allergy season here in Virginia. Our goal is to expand this policy to the greater population. But this is a rule that's already passed as it applies to youth. So we've made great progress on this front. And this not only reduces recidivism, but it reduces the chance of relapse. The first 2 weeks post-release are the most dangerous time for someone who is coming out of jail. If they're going to commit another crime, or if they're going to relapse, or if they're going to engage in substance use disorder, I know many people don't like that word relapse. Odds are good, 80%, that it's going to happen in those first 2 weeks. If you can be released and be covered by Medicaid and know where to get your services, cuts that drastically. So we were really proud to be part of this effort. Finally, there's something called the Second Chance Act that's due for reauthorization. Second Chance Act is a bill that passed many years ago that gave people being released from prison more opportunities to gain employment, gain access to social services, so on and so forth. When a bill is reauthorized, that means it's a chance to expand its scope. And the two areas that the House and Senate, the advocates for this, have been pushing to see reauthorized are greater access to stable housing and better access to peer support services and case management. If we can get those in the bill and we can get the bill passed, again, we'd be doing more to cut recidivism. The number one indicator of whether a person can maintain their recovery is stable housing. It's really important to us to see this through. We've been working with this on a bipartisan basis. We have support in the House and Senate from both parties. Again, it's just finding the window to move it through. Congressional sessions right before a presidential transition tend to be quite busy. And we'll just have to see if the right window presents itself to move this legislation through. Last thing I want to talk about in terms of what we've seen in the past as we transition to the future is the CDC. This is the Centers for Disease Control, and they have a program called Overdose Data to Action. This is data that's processed by the CDC and given to states so they know where the problem areas are in overdose in their states, so they know where to invest. Critical information for the states from the CDC. I remember when this program was born, I believe it was funded at somewhere around $100 million, and that was about 8 or 9 years ago. I believe that was in 2015 or 16. It's now up to $500 million that is invested in this program. So states have better information on overdoses occurring within their borders. In this year's appropriations bill, which is funding for the federal government, which includes the CDC, the House of Representatives has a long list of grievances with the CDC. A lot of it stems from COVID. A lot of it stems from research they do that members of Congress consider controversial, like gun violence or LGBTQ health. But what the CDC proposed was eliminating the entire Injury Prevention Center, which, guess what, includes Overdose Data to Action. The impact will not only be felt at the state level, but we felt at the county level. Remember what I said before about counties. The funding from overdose data to action, that $500 million I mentioned, less than half, probably less than a third, goes to state departments of health. The rest go to cities and counties directly. Alameda County gets $2 million a year, for example. Los Angeles County, Clark County in Nevada, King County in Seattle, Cook County in Illinois. They get money directly from the CDC so they can keep tabs on overdoses within their borders so they know how best to address it. That money is at risk because the House of Representatives refuses to fund it. The Senate took the exact opposite approach. They proposed fully funding it. I want you to keep this in mind as we transition and talk about the future. The House, in the same report that they proposed cutting this $500 million program, took a very antagonistic attitude towards harm reduction. I know harm reduction can be controversial. I don't pretend to know all of your opinions on it. But this is what the House had to say about harm reduction. They expressed a concern, or their concerns, and said other than naloxone, which is overdose reversal, they have no interest in continuing to fund harm reduction programs. So moving forward into the next administration, I would expect this trend to continue. What is considered harm reduction? How frequently it's used? How it's funded? All questions for debate and to be answered at another time. But the House has started to take a very antagonistic view towards harm reduction. And a concern I have is that the next administration is probably going to be thinking along the same lines. Regardless of evidence, where school-based substance misuse screening, brief intervention, and referrals to treatment programs have produced returns of as high as $20 on every $1. The reason I say this is because the House of Representatives does not think that SBIRT is a worthwhile investment because they believe it invests in harm reduction. A lot of this is spurred by misinformation, but believe me, when it's in the report, you can pretty much count on the fact that that's the House's position. So, as we talk about what the future awaits, let's talk about, where we see things going. We have two opportunities to evaluate where the Trump White House will go on these policies. One, we have experienced a Trump White House in the past, from 2017 to 2021. We have seen the Trump White House in action. We have worked with them. We have a sense of what their priorities are and what their priorities are not. Two, what has been said on the campaign trail, which from any politician, Kamala Harris, Donald Trump, Joe Biden, Bill Clinton, Gavin Newsom. What is said on the campaign trail is said on the campaign trail. Do not take it as gospel. But it does give you a sense of priorities and direction. When it comes to the Trump administration's attitude towards substance use disorder, it is almost certainly going to be an enforcement-first approach. He has already put people in his cabinet, or has recommended that he will put people in his cabinet. I can't say he's put anyone in his cabinet yet because he's not the president yet. He has indicated that he will nominate for his cabinet people who favor a very law enforcement heavy approach to substance use. Very much a war on drugs kind of attitude. That doesn't mean that there will be no place for things like treatment and recovery. It just means those things won't frame the narrative. We will continue to advocate for workforce, medication-assisted treatment, recovery support services, Medicare and Medicaid coverage, down the line. Our job does not change. It becomes harder, but it does not change. But from this Trump White House, don't expect those kinds of issues to be in the lead like they were in the Biden-Harris White House. The White House's direction on drug policy is usually reflected through ONDCP, the Office of National Drug Control Policy. The head of this office used to be referred to as the drug czar. The last few haven't liked that title. They've just gone by director of ONDCP. The role of ONDCP is going to be hard to predict. As I said, I do sense an enforcement first approach, but we have to think, will there be an ONDCP at all? If you look at the documents that will be guiding the Trump administration's priorities, such as Project 2025 and others, and if you listen to people he says will have influence, such as Elon Musk, there are considerable questions as to the future of ONDCP. Will it continue to exist in its current form? Or will parts of it, such as what we call HIDTA, the high-intensity drug trafficking areas, will those be moved out to, say, the DEA, the Department of Justice, for example? It's hard to know. And the reason I don't have slides on things like this is because so much has happened in the last few days that it's almost hard to keep up. If this had been 1 week later or 1 week earlier, it'd be a completely different webinar with completely different slides. But the appointment of certain, or the proposed appointment of certain people, whether they be Homeland Security, Director of National Intelligence, National Security Advisor, they dictate all these things. I think, the potential nominee for National Security Advisor is someone who has, in the past, recommended, quote, bombing the Mexican drug cartels. So, hey, I'm not saying if that's a good idea or a bad idea. I'm just saying the focus doesn't seem to be on treatment and recovery right now. That's all. Another issue I'm getting a lot of questions on is cannabis. Everyone expected, the Obama White House, as we know, followed something called the Cole Memo and threw this to the states and said, hey, you want to do your own thing on cannabis, legalize it for therapeutic purposes, recreational purposes, in whatever form, in whatever retail, you go ahead and do it. When Trump took office and Jeff Sessions was named his attorney general, we all who work on this issue thought, that's over. Very law and order oriented administration. We thought that's over. Turns out that Trump's Department of Justice recommended to him to follow the Cole Memo and just keep things as they were. So I know that President Biden this summer talked about rescheduling marijuana, taking it off Schedule 1. Kamala Harris in her campaign talked about a full across-the-board legalization of cannabis. And a lot of people assumed that if Trump were to be elected, all those things would be back off the table. Well, his nominee for Attorney General, Matt Gaetz, actually has some fairly, call it liberal, views on marijuana and on cannabis, and is not someone who would take the approach that it should necessarily be outlawed 100% federally off the bat, or even kept on Schedule 1. Now, those of you who follow the news will know there is no guarantee that Matt Gaetz is going to be the Attorney General. He may be, he may not. The Senate has to confirm him. But if he is, we could see some policies towards marijuana or cannabis, excuse me, that are a little surprising from an administration like this. So from an administration as conservative as this one. So we're going to have to wait and see on this. In the moment, it is in the hands of the states. And I found this really interesting, and I wanted to share this with you. 4 states had referenda on cannabis this past election, and 3 rejected it. This kind of bucks some trends. We have seen some real, we've seen state after state legalizing recreational cannabis. I don't know if this was a result of a more informed electorate, or not every referendum in every state is the same. See, I know for a fact that when Ohio had this referendum, I think back in 2018, the main reason it was rejected was because it would have given only 3 companies a complete monopoly. There would have been no free market. And a lot of people didn't like that. So it was rejected. It had very little to do, or we think it didn't have everything to do with whether cannabis should be 100% legal for recreational purposes or not. It had to do with the way it would work within that state. So here you see the ones that were rejected, Florida, North Dakota, and South Dakota, all have different language. One was for possession of up to 3 ounces. One was concerning growing 3 plants. One was concerning distribution. They're all different, but they were all rejected, with the exception of Nebraska. Yeah, it's going to be real interesting to watch from a federal perspective what they do on cannabis. Can the states and the federal government find a balance on this issue? Just wanted to give you the results, hovering between 51, 55% on cannabis. Massachusetts was interesting too. Massachusetts referendum was on psychedelics, and that failed as well. So you have a real mix of states here. South Dakota and North Dakota, rural, conservative. Massachusetts, not so much. Urban and suburban, more liberal. Still, similar results. So real interesting in terms of attitudes towards this issue. So because this is a Trump White House, and in the first Trump White House, there was an attempt to repeal the ACA, that is a question on everyone's mind. Will there be an attempted repeal of the ACA? And what will the impact be on Medicaid? That is more of a question, I wouldn't say more, but that has nothing to do, that is not strictly the domain of the White House. Congress obviously has a major say in this. Many of you, if not all of you, work with Medicaid and Medicare and know the importance of Medicaid in behavioral health, the role it can play in terms of the populations we serve. I want to refresh everyone's memory or tell you something new if you didn't know this. In 2017, when there was an attempt to repeal the ACA, it went further than that. It wasn't just a, hey, we're going to undo the coverage and the mandates of the ACA, and that'll be it. What they proposed was, in addition, something called a block grant of Medicaid. This is the stuff we are really concerned about. Currently, Medicaid is open-ended. If someone comes in for services and they're covered by Medicaid, and the services are cleared and provided, Medicaid is billed, and that's it. The proposal in 2017 was to block grant Medicaid, which meant a state would get a finite amount to fund Medicaid for the year, and once it was expended, you're done. Now, I want you to imagine you're a provider in North Carolina that relies on Medicaid, and say I don't know, hurricane destroys an area of your state the size of Massachusetts. And thousands of people who are covered by Medicaid require services which will result in millions of dollars of costs. And you burn through your allotment, and it's September, and the money's gone. What are you going to do for the next 3 months? That's what we're concerned about. So am I concerned about the ACA? A little. Personally, I think that they're going to, what we say in DC, nibble around the margins, take away a little bit here, a little bit there. I don't think a straight up repeal is in the cards, although you never know. And I'm not in the business of having a crystal ball, because if I had a crystal ball, I could probably make a lot more money in another line of work, but I don't. But what I'm really concerned about is the potential block grants for Medicaid, and whether Congress, and we'll know within the first 100 days of the Trump presidency whether that is the plan or not. How will they do this? I don't have time to get into it, but through a process called reconciliation. We all know that the Republican majority and the Republican White House wants tax cuts, corporate tax cuts, make the Trump tax cuts from the first term permanent. That costs money. That means the government needs to offset the costs. And the easiest targets are always Medicare and Medicaid. So that's what we're concerned about. Usually I don't sit here as a behavioral health advocate and talk about tax policy, but be on the lookout. If the Republican House and Senate look to move a tax package in the first 100 days through the reconciliation process, which I do not have time to get into, they are going to need to find offsets. That's the law. And we are very worried that Medicaid could be one of those offsets. Not the entire program, but several $1 billion worth. Remember what I said before about not taking everything a candidate says on the campaign trail seriously. There was an article in NPR about something that was said on the campaign trail. Trump said that his solution for the homeless problem, especially in states like California and Oregon, is to bring back mental institutions. This is not likely, in large part because of Medicaid policy. So the reason I bring this up is, once again, to show you what the overall attitudes are. I don't think this White House, and I learned this in the first Trump White House, their messaging is not very nuanced. When he says something like this, does it mean he's going to try and make it a reality? Not necessarily. But what it does show is that his line of thinking, when it comes to things like treatment, like recovery, is not nuanced. It is going to be our job to try and bring that nuance to the table. If the White House wants to talk about enforcement and trafficking and mental institutions, that's fine. That's their prerogative. They won. It's their policy to set. It is not our place to go in and say, you are wrong. It is our place to go in and say, would you also consider greater workforce, greater coverage, and things like that. So it is going to be a matter of finding those opportunities where we can when the discussions come up. This is a little bit more about that last slide, which I don't think has much chance of becoming reality, but I think it just shows you kind of a, message that comes more from the 80s than from 2020. So we have some challenging times ahead. I know a lot of people like to think that there may be opportunities, and there always are. But, it's how we frame this and how we bring it to the attention of policymakers is going to be critical. That's my last slide. If there's any questions, we've left a little time to answer them, and I'm happy to talk.
Any questions, please put them in the chat. Okay, it looks like we don't have any questions. So I want to thank Andrew Kessler for presenting today. Thanks as well for you for participating. We hope you join us for future NBHAP webinars. You can sign up for our various newsletters at our website, www.nbhap.org. With that, this concludes today's webinar. Thanks again.